Good evening, everyone, and welcome to our Veterinary Teleneurology Facebook Live. It's 7 o'clock here in the UK, and as you can see, it's extremely hot thanks to global warming. It's about 30 degrees at this time, and probably a few more degrees in my office, which is at the top of the house in the attic. Tonight, we are delighted to have with us John Rossmeisl, who is from the US. He's professor in neurology and neurosurgery at Virginia, Maryland College of Veterinary Medicine. And as I mentioned to you a couple of weeks ago, Simon and I wanted to try something new with you, and we came up with this idea of journal club. The idea behind that is that a lot of you are very busy on clinic. Even if you're passionate about neurology, you don't always have the time to actually read the article and to keep yourself up to date. And who will be best to present this article than the author himself or herself? And that's the reason why we came up with this idea. And tonight, John has kindly accepted to try that with us. And we hope that you like the concept. Feel free to give any feedback if you want us to change anything. Glad to see that we got so many people from across the globe. Again, we have people from Brazil, Uruguay, Colombia, moving on to Europe, people from the Netherlands to Russia, Taiwan. So great again to see so many of you joining us regardless of the time of the day. As I say, John is a very old friend of Simon and I. I think John and I, we know each other since about 17 years when we did that paper on the Great Dane with orthostatic tremor. That brings back a lot of memory. John is, an eminent neurologist, both in the field of, medical and neurosurgery. He's done a lot of publication, and his latest publication, which was published on an early view in GVIM, is the one that he will present tonight, looking at the comparison between direct assessment of intracranial pressure and all the other marker of raised intracranial pressure, either clinical or MRI. So, John, thanks a lot for joining us tonight and accepting, to try this concept of journal club. Simon will ask John, a number of questions relating to the article. In the meantime, feel free to put in the comment box any question that you want me to ask John at the end of his presentation, and hopefully, you will enjoy this new concept. Simon, over to you, and good luck to everyone. Thank you.
Great, thanks very much, and good evening, good morning, good afternoon to everyone watching, wherever you are. Thanks for tuning in, and it's a pleasure to welcome John here, an honor for us. Thanks very much, John. Sorry that you're the guinea pig here in this first of the of many, hopefully, Journal Club events. But what a way to start. This is a great paper, and it really pushes us forward, I think, in many areas. And so I guess where we want to start then is your interpretation of what the background of this article is, like set us up for your thoughts on how it was necessary and how it developed.
Yeah, thanks. Well, first, thanks for having me, Laurent. I'm glad I could be a trial and error type case. I think this is a wonderful idea, especially given the world we're living in these days, and so it's a great way to unite the community. So it's my honor to be on the program. So why did we do the study? So originally, we designed the study because there's a paucity of data on what the intracranial pressures are in dogs with naturally occurring brain disease. Us as neurologists, we commonly incriminate intracranial hypertension as a major mechanism for dogs having neurological decline and deterioration at their intracranial pressure going up, particularly those dogs that have space-occupying mass lesions like brain tumors. The technology we used to do the study had been around for quite some time when we actually thought about doing this study. And we had some clinical trials in dogs with brain tumors that we know we were going to measure their intracranial pressure. We were trying to look for a practical, economical, and feasible device to do that. And I figured, well, we've been estimating or trying to predict what the intracranial pressure in these dogs was for a long time. So I said, well, why don't we measure it and see what it is and then compare it to those surrogates of intracranial pressure that we commonly apply to our patients. So clinical exam findings, and also MRI findings. There's been a couple of nice papers before that have looked at these surrogates to see if we can predict or identify dogs with intracranial hypertension. But unfortunately, because of the invasiveness of direct intracranial pressure monitoring, there really hasn't been any validation of those surrogates by comparing those to direct intracranial pressure measurements in dogs.
Right, excellent. Well, thanks for setting us up a little bit. But you lead us into that next question, and that is a little bit on what currently is available, just a review for people listening, to assess intracranial pressure, both clinical imaging techniques and then the direct methods.
Yeah, so you know, our neurological examination as neurologists, that's our most important tool in our arsenal. So, you know, the clinical findings and our neurological examination findings, you know, work that you did a long time ago, we applying the Glasgow Coma Scale score to animals to assess their consciousness, their brainstem reflexes, and also their motor activity. So clinical signs are pretty important for us to use. There are some non-invasive methods that several groups have looked at to try to estimate intracranial pressure. And there's a lot of new technologies that are out there now as well that you can do that. So you can measure the transcranial Doppler signal in the cerebrovascular system and look for their vascular resistive indices. And you can do that with most ultrasound probes that many of us probably have in our practices. You can actually measure the optic nerves diameter with ultrasound. So you can do ocular ultrasound and measure the optic nerve diameter, and if there's intracranial pressure that's enlarged, you can do your fundic exam and look for clinical signs of intracranial pressure like papillary edema. And several groups have looked at trying to estimate the intracranial pressure with various MRI signs of numerous MRI signs. The papers that come to mind, and I've got a slide if that's helpful for the audience. Let me share my. Hopefully you can see that slide that says surrogates of intracranial pressure in dogs with brain disease. Can we see that?
Yep.
Yep. So these are actually the most recent studies that have looked at these non-invasive techniques. And so Dr. Bitterman's group looked at 91 dogs in which they presumptively characterized dogs based on their clinical presentation, including their level of consciousness, as well as their pupillary size and symmetry, and their fundoscopic score. So again, looking for papilledema, and then they gave them a score based on their clinical presentation as whether they had presumed intracranial hypertension or not. And then they compared those with those individual dogs' brain MRIs, and they looked at multiple brain MRI criteria and a variety of different intracranial diseases. And they found some pretty striking findings, like the odds ratios for mass effect, brain herniations, caudal displacement of the lamina quadrigemina, you know, we're on the order of 20 to 30 times the risk of having intracranial hypertension if you had any number of those MRI indicators of intracranial hypertension. Dr. Scrivani's study they measured on the T2 transverse sequences the optic nerve sheath diameter in dogs, again, with and without presumed intracranial hypertension based on clinical presentations. And they found that the optic nerve sheath diameter and the optic nerve body weight ratio was significantly increased in animals that had presumed intracranial hypertension. And then finally, Dr. Sasoka from Japan at the bottom looked at transcranial Doppler ultrasound exams in dogs with suspected intracranial hypertension. And they found a significant change in one of the cerebrovascular indices in dogs that had presumed intracranial hypertension. But again, I think that these studies were great, but the limitation was they really did not validate what they saw or what they presumed to be intracranial hypertension with a directly measured intracranial pressure.
John, sorry to interrupt you. If there's any chance you could expand your screen.
Yes,
that would
I
be
can
great.
do that. Sorry about that.
No worries.
Great. Well, thanks for that
overview
then of those methods, which then does walk again nicely into the next question, based on the fact that you're going to use some direct measures of intracranial pressure. What could you summarize as being the objectives and hypothesis for your own study? Yeah,
so our objectives, when we started this study, there was actually, and we'll talk about this in the methodology a little bit. Our primary objective was we wanted to evaluate the feasibility of using intraoperative direct intracranial pressure monitoring with a a piezoelectric catheter strain gauge microsensor in dogs with brain tumors. And this is a particular instrument that you can use to measure intracranial pressure. And at the time we started our study, there were no publications looking at the utility of this particular instrument in dogs. You know, there's lots of other technologies that have been used in dogs to measure intracranial pressure, predominantly fiber optic sensors or direct hydraulically coupled catheters placed in the ventricle. But this particular instrument that we looked at had not really been used in dogs with spontaneous disease. And so our hypotheses based on our study population was we wanted to determine if the intracranial pressure were different between dogs that had brain tumors and healthy normal dogs. And we hypothesized that dogs with brain tumors would have a higher intracranial pressure than controls. And we also wanted to determine if indirect clinical or MRI surrogates of presumed intracranial hypertension could discriminate dogs with and without an elevated intracranial pressure. And our hypotheses there, we had two of them, was that dogs with clinical or MRI indicators of presumed intracranial hypertension would have a higher direct intracranial pressure than those dogs without those features.
Okay, so then I know there was a lot of work that went into this, but are you able to summarize your materials and methods, then how you went on to evaluate that hypothesis?
Yeah, so our study population, again, we had dogs that had histologically confirmed gliomas that were scheduled to have therapeutic procedures in which we would be placing catheters or electrodes in their brain. And so we knew they were going to be having surgery, and we knew they had gliomas. And so our methods to evaluate them clinically, so the day of their surgical procedure, each dog had a clinical exam by a neurologist, and we recorded their Karnofsky Performance Scale score, their Modified Glasgow Coma Scale score, and also their fundoscopic scores. And those are scores that have been used before by some of those papers I mentioned about trying to estimate intracranial hypertension based on clinical status. And then all animals had a brain MRI pretty close, in close proximity to their intracranial monitoring procedure. So 2 to 4 days prior to their intracranial monitoring procedure, they had a brain MRI examination. And we took each animal's brain MRI, and then 3 participants in the study that were blinded to the intracranial pressure readings recorded qualitative and quantitative MRI indicators of presumed intracranial hypertension. And the specific MRI variables that we looked at were sulcal effacement, presence of brain herniations, 3rd and 4th ventricular compression, perilesional edema, fault shift greater than 3 millimeters, displacement of the lamina quadrigemina. And we considered that 3 or more of these features present would have presumed intracranial hypertension based on their MRI. And we chose these particular MRI variables because those 2 studies I showed you before, the Bitterman study and the Scrivani study, had shown that these particular MRI features had the most significant association with presumed intracranial hypertension. And then we also did some quantitative measurements. We measured the T2 lesion volume, the T2 weighted volume of the brain, the T2 lesion and brain tumor ratio, and then also the optic nerve sheath diameter using the T2 transverse sequences, and then converted that to an optic nerve sheath diameter to body weight ratio. So for those of you not familiar with a small animal Karnofsky Performance Scale score, there's been a couple of publications that have looked at this. We've been using this in canine brain tumor trials for almost 10 years now. And so we applied the Karnofsky Performance Score to these patients, and also used the Modified Glasgow Coma Scale, which most of us, I'm assuming, are familiar with, originally published by Simon back in the early part of this century. So I will tell you that to qualify the population that we enrolled in this study, to qualify for the study, these dogs generally had mild to moderate neurological dysfunction. So in order to qualify for our study, they cannot have a Karnofsky Performance Scale score less than 60. So these are animals that actually have mild to moderate neurological dysfunction. And then finally, we came up with a composite clinical scoring system based on all of these factors to try to put a numerical score on the clinical severity of the individual animal's disease. And you can see how we actually calculated that. The fundoscopic score is, again, modified from the Bitterman study. A normal score is a normal fundoscopic exam. And you can see on the bottom right, a dog that had papilledema would receive a score of 1. And then we created an adjusted score based on these and assigned the animal a composite clinical score. We considered a composite clinical score greater than or equal to 4 indicative of presumptive intracranial hypertension. So to actually measure the direct intracranial pressure, we actually used the Codman Microsystem ICP Express instrument. And this has a lot of potential benefits. Actually, after we started this study in 2018 and 2019, there's been 3 nice publications that have actually used this to measure intracranial pressure in dogs. One out of Davis by Dr. Sturges measured the intracranial pressure in normal dogs using this instrument, both under anesthetized conditions while they were awake and in various body positions, and also used to see if you could use this instrument by placing the sensor intraparenchymally, so within the cerebral parenchyma, or actually subdurally. And they found that intracranial pressure were not significantly different regardless of the way you place the catheter. So subdural and intraparenchymal placements resulted in similar intracranial pressures. The nice thing about this instrument compared to, say, a fiber optic ICP system is that this has little titanium piezoelectric crystal at the end. And so the force applied to this crystal actually gets translated into a voltage that is directly proportional to the applied force, and in this case, the intracranial pressure. And this is a nice 1 meter flexible, small diameter. The catheter, the transducer, is very small diameter and very flexible. So it's very practical to use compared to those quite sensitive and quite fragile fiber optic intracranial pressure sensors, for those of you that have looked at it. Another nice thing about this is that it's quite economical. You can buy these intracranial pressure transducers for $50 to $100 US each, and you can get a refurbished ICP Express monitor for less than $200. So this is actually quite an economical system to use to monitor the intracranial pressure. The other really nice thing that intrigued me is that these micro transducers are actually MRI compatible up to 3 Tesla. So you can actually monitor their intracranial pressure in the MR, which we did in our normal animals in this study. You can actually see the micro transducer, since it actually has a titanium little bouton at the end, creates a little bit of a bloom artifact that you can actually see, but it's quite small. And what we did is we placed these intracranial pressures 10 millimeters into the cerebral parenchyma in order to obtain our intraparenchymal pressure recordings. And in the dogs with the brain tumors, we actually did this by placing these through what we call a probe guide pedestal. We implant these probe guide pedestals into the brain, and we can pass catheters to do drug delivery, direct interstitial drug delivery to the brain, or electrodes if we're doing tumor ablations. And we essentially pass the intracranial pressure transducer through one of these holes into macroscopically normal brain parenchyma, and then recorded their intracranial pressure every 15 minutes prior to the onset of their therapeutic intervention. And then we also recorded their mean arterial pressure from a dorsal pedal arterial catheter every 5 minutes, and then calculated their cerebral perfusion pressure from those physiologic variables. And that's essentially our methodology.
Well, a lot of work there, a lot of work. So congratulations on that. Now, leading into the results, how then did your direct intracranial pressure measurement compare to those potential markers of intracranial hypertension on MRI and presumed intracranial hypertension clinical signs? Yeah,
So first, let me just review the clinical variables between the different groups. So here's a table. This is table 2 from the paper. This actually table is a summary of the comparison of the clinical variables and composite clinical scores between each of the groups. And in this particular study, when we're talking about groups, I'm talking about control dogs, which was 3, versus the tumor dogs, which was 20. Dogs with a clinically predicted normal intracranial pressure versus dogs with a clinically predicted intracranial hypertension, and then dogs with MRI predicted normal ICP, or dogs with intracranial hypertension predicted based on their MRI. And what you can see here is that dogs with brain tumors, not surprisingly, have significantly worse clinical scores than controls. Dogs with clinically predicted intracranial hypertension had significantly worse clinical scores than dogs with presumed normal intracranial pressure. And then we did not find any significant difference in clinical scores between the MRI predicted groups. If you look at the direct intracranial pressure measurement, so going back to hypothesis 1, that dogs with brain tumors would have significantly higher intracranial pressures than controls, we had to reject this hypothesis. We did not find a significant difference between the direct intracranial pressure measurements from normal dogs, which the time average was about 10.4 millimeters of mercury, versus dogs with tumors. Their time average ICP was 15.6, and that was not significantly different. We also found no significant differences in the mean arterial pressures between those two groups, nor the cerebral perfusion pressures between those two groups. Dogs that had we also had to reject hypothesis 2A in that we did not find a significant difference in the intracranial pressures between dogs with clinically predicted intracranial hypertension versus dogs with a clinically predicted normal intracranial pressure. So clinical prediction intracranial hypertension had a mean of 16.4 versus 12.3 for those dogs with a clinically predicted normal ICP. And again here, no significant differences between mean arterial pressures or cerebral perfusion pressures between these two groups either. But the MRI data is where it starts to get interesting. So we did find a significant difference in intracranial pressures in those dogs that were predicted to have intracranial hypertension based on their MRI. So their time average intracranial pressure was 19.2 versus 10.3 for the MRI predicted normal intracranial pressure group, and that was significantly different. Although we did find differences in their intracranial pressure, there were no significant differences between MRI predicted groups' mean arterial pressure or the MRI predicted group's cerebral perfusion pressure. So we did accept hypothesis 2B. So MRI did discriminate between dogs with and without elevated intracranial pressure. So if you look at the inter-observer rater agreement for our qualitative MRI variables, actually the observers performed well. So there was, in general, very good agreement between the observers for the presence or absence of these qualitative MRI surrogates of intracranial hypertension, which is summarized in this data table here. The lamina quadrigemina position was really the poorest performing category, and there was still moderate agreement between the observers there. And so again, with our study, the presence of 3 or more of these MRI features would be equivalent, which we assumed would be equivalent with presumptive intracranial hypertension. If you look at the feature comparisons of the MRI between the groups, all of these variables except for sulci effacement and actually fourth ventricular compression were significantly higher, or they were significantly more likely to be present in dogs that had predicted intracranial hypertension. And I think the most striking thing here, as far as from a practical clinical standpoint, is that we did not find any dog with a predicted normal intracranial pressure to have a transtentorial foramen magnum or subfalcine herniation or a caudally displaced lamina quadrigemina. So structural anatomic shifts on MRI were highly predictive of presumed intracranial hypertension in this population of dogs. And then finally, for the quantitative MRI features, we also found significant differences in, so dogs that had MRI predicted intracranial hypertension intuitively and significantly had much larger tumor burdens and larger optic nerve sheath diameters than those with dogs with predicted normal intracranial pressure. So measuring the optic nerve sheath diameter on T2 weighted MRI images is helpful, and dogs with bigger lesions are much more likely to have intracranial hypertension.
Great. Oh,
one more
sorry.
thing, Simon.
Don't interrupt. Keep going. Keep going.
Okay, sorry. So we also did some receiver operating characteristic curves, right? And so the AUC statistic of the receiver operating curve essentially, quantifies the overall ability of a test to discriminate between those individuals who have a disease, in this case intracranial hypertension, and those that do not, based on both the sensitivity and specificity of the test performance. And so MRI in our study, if we define intracranial hypertension as greater than 15 millimeters of mercury, so that's the threshold for hypertension in this particular model, the MRI had a sensitivity of 90% and a specificity of 69%. And the AUC was 0.8. And there's the 95% confidence interval there. If you look at our composite clinical scoring system, that had a sensitivity of 70% and a specificity of 46% at the same threshold. And if you look at the AUC statistic, it's almost a useless test. So on the right-hand side of the screen, an AUC of 50 essentially is a useless test, and our clinical scoring system did not perform much better than that. And so that particular thing, based on our results, clinical scoring system is not very valuable to discriminate dogs with and without intracranial hypertension within the context of this population. Now I think I'm okay, Simon.
Okay, sorry again. Great summary of your data there. Thanks very much. Thanks very much for that. You're welcome for the next question to say there were none, But the next question is, what would you, looking back at this, what would you say the limitations of the study are, or how would you do it differently if you would do it again?
Yeah, so the limitations of this study, I think, was that we had a pretty homogeneous population of animals with disease, right? So we had one disease, one tumor type, exclusively a forebrain localization. The dogs had mild to moderate neurologic dysfunction, so we didn't have very severely affected animals. All dogs were treated preoperatively with steroids, which could have definitely altered their intracranial pressures. And we really, overall, the dogs in our study had relatively mild intracranial hypertension. Let me go. This is a graph of the individual intracranial pressure values for all the dogs in our study. And, really looking at normative data for dog intracranial pressures, over 15 might be an elevated intracranial pressure depending on the age and body size and potentially skull conformation of the patient. Over 20 millimeters of mercury is definitely an elevated intracranial pressure in dogs based on the data we had, but we had very few dogs with significantly increased intracranial pressures. If I had to do this over again, I would like to have compared this to some non-invasive methods of intracranial pressure assessment, like an ultrasound assessment of the optic nerve sheath diameter, or perhaps transcranial Doppler ultrasonography. But we simply didn't do that. It'd be nice to have a non-invasive bedside test to compare this to that we can use in the clinic without having to do something invasive to our patients or anesthetize them.
Okay, and then finishing up, and you're welcome then to summarize here. Really, is what would you think then is your main take-home message or take-home points for the audience today?
Yeah, so my main take-home points are that this is a very feasible technique, an economical technique that you can use in animals and dogs with brain disease. If you're going to be, especially if you're going to be doing intracranial surgical manipulations. And I think this kind of technology and this instrument opens the door for us to have some data-driven studies on prognostic impacts of intracranial hypertension and the effects of the therapeutics that we oftentimes use to treat presumed intracranial hypertension on dogs with brain disease. So, for example, does administering hypertonic saline actually make a difference when we see these MRI findings clinically or prognostically related to their disease? One of the papers I mentioned earlier in this study by Dr. Sakai out of Japan, they looked at 17 dogs with brain tumors, and they actually used the same DICP monitoring instrument that we did. And what they found in their study, they found that dogs that had an elevated intracranial pressure after surgical resection of their brain tumor, and they defined intracranial pressure elevation as greater than 13 millimeters of mercury in that particular study, had a significantly more likely, significantly increased risk of having acute perioperative mortality. So perhaps intracranial pressure can be prognostic in animals with brain disease, and we definitely need to look at that more. And then practically, when we see these multiple MRI features of intracranial hypertension while our dogs are in this MRI scanner, do we need to treat them? And when should we treat them? And kind of what are the clinical criteria to use? Because based on our study, those clinical criteria seem to be quite insensitive. And how should we treat them? So, and I think that's another big take-home point. Clinical evaluation of these patients, they can have pretty significant lesion burdens and pretty significantly elevated intracranial pressures and not have any overt specific clinical manifestations of that or any clinical manifestations of brain herniations. And that's been shown in several other prior papers.
Great. Thank you very much for wrapping it up like that, John. And as always, we know this is a team effort, so I wanted to thank your team that are involved in putting this together, as well as yourself. And also, obviously, thanking you for taking time out of your busy day. I know that you are currently on clinic, so thanks very much for being the first one up for the live online journal club and disseminating this information, which is important and has some really great practical implications there. So I'm going to hand you back to Laurent now, who, as he said, is stuck in his attic, and hopefully has some questions from the audience.
Sure thing.
Thanks a lot, John. Great, great talk. I think maybe it would be interesting for the audience. You mentioned to someone, and are you involved in a number of research and so on? I don't know if you wanted to mention anything about it, and if there was any case. call for case you wanted to recruit and so on.
Oh, sure. Yeah. Thanks for the free plug. I appreciate that. So I would also like to take this opportunity to thank my team. This was done by several of my PhD students and residents, Dr. Giannassi's, Dr. Connie. So they did most of this work. So that was great. And I really thank them. And they also helped me put together this presentation. So I really appreciate that. And I'd also like to thank the National Cancer Institute for funding this study. And so I do have some open clinical trials for dogs that actually have what look like gliomas on MRI. And we can actually, I have a couple of different trials that we could enroll them in. We have a trial to look at molecularly targeted cytotoxins that we infuse using convection enhanced delivery. And that's actually what most of these dogs were treated with in this particular study. And we also have another study that is open now that we're actually is an extension of our previous work using electroporation to ablate tumors. We can now do that with MRI guidance. And so we will actually have a trial open as soon as our university fully opens to treat dogs with gliomas with that as well. And so my contact information, feel free to reach out to me. I'll give that to Drs. Platt and Grossi, and they can forward you if you have any questions or patients that may qualify for those studies.
Yeah, so please feel free, to message us on our Facebook page if you want the detail, to be involved in any of the study run by John. So we've got some really good questions actually. The first one, John, for you, you can actually see it on the screen. Could the craniotomy for biopsy device insertion have any bearing on the ICP being lower than expected on clinically or MRI?
Absolutely. Yeah, it's been shown, a craniotomy, particularly with an extensive durotomy, is probably one of the most, reliable ways to reduce the intracranial pressure. So yes, that could have had an adverse effect on the intracranial pressure. But one of the strengths, I think, of this study is that every single dog was treated with a minimally invasive craniotomy, so very small. So at the most, it was about 1 centimeter in diameter, and a single dural puncture. So the same kind of dural puncture you would use, just large enough to put in that intracranial pressure monitoring device. So a very limited dural puncture. So all dogs were treated the same, all dogs were anesthetized the same, and all dogs were immobilized in a stereotactic head frame, so their head position was constant during the monitoring procedure. So those variables were all controlled. So yes, it could have had an influence on it, but that influence should have been relatively equal across the study population.
Yeah. There's another one about the clinical assessment was not very sensitive, but this population had a chronic condition. Do you think that this chronicity affected the clinical assessment due to autoregulation?
Yes, I think the very nature of this population probably affected the clinical presentation. I can tell you that some of these patients were much worse off clinically before they actually saw corticosteroids. And so I think the chronicity of their condition, and we're talking chronically here, most of these animals were diagnosed via MRI and then had their intracranial pressure monitored within a month of having their MRI diagnosis. So I would say more like a subacute condition in this population, but absolutely the corticosteroid treatment, and I can tell you from doing serial MRIs on several of these patients that the corticosteroids reduce the peritumoral edema burden that many of these dogs actually had. So yes, and again, by design, this study excluded dogs with severe clinical conditions, right? So our inclusion criteria was mild to moderate, animals with mild to moderate neurologic dysfunction. Mm-hmm. So that is a bias of the study.
Another one regarding the treatment, you mentioned about steroid. Was mannitol, hypertonic saline, administered during surgery in this dog to put the device?
No. So the only medical treatment administered for intracranial pressure was the corticosteroid treatment. We did not administer mannitol or hypertonic saline in any dog.
Another one from Cohen, with a very young and very talented neurology resident in Holland. If we accept this result that say dogs with brain tumor do not have significantly elevated ICP compared to normal dog, would that meaning for the statement often heard that dog with brain tumor might have a headache, which is important to an vets and patient, as in ICP difference will not be an argument in favor of such a statement. Foot more factor might be associated with headache addition to ICP.
Yeah, great question. So in my years of experience, I do think that dogs with brain tumors can oftentimes have a headache. What are the mechanisms that anthropomorphizing a little bit. I do think there are potentially many factors that are associated with it. It's particularly like with gliomas, an example I use is there are many gliomas, oligodendrogliomas in particular, that have a lot of meningeal contact and meningitis associated with them, and we know that can cause discomfort and referred head and or neck pain. And again, this study is not generalizable to every dog with a brain tumor. I think there are many dogs out there when they come into our clinic before they actually have any treatment that might have a significant increase in their intracranial pressure. And those dogs, I think, is pretty common to have clinical signs that would be associated with potentially a headache.
And the last question for you, John, taking 20 millimeter of mercury as a threshold for ICP, do you have stat or any information about sensitivity, specificity of the MRI to decrease ICP?
Yes, I do. Bear with me for 1 second, and I will tell you what that is. We looked at intracranial pressure thresholds of 10, 15, 20, and 25. So for an ICP threshold of 20 millimeters of mercury, the sensitivity for that, for MRI, was 75%, and the specificity was 47%.
Here we go. You want number? We got them. Thank you very much, John. I think there's no more question.
Okay.
Again, brilliant. We didn't expect anything less, from you. Before I give the mic to Simon, just to let everyone know what we got in plan for next week. Again, we try to do this journal club on the monthly basis, but next week we've got another good friend of Simon, Shannon Holmes, who is a specialist in radiology, talking about imaging of brain trauma. So join us again roughly at the same time. We'll be advertising that, as well next week. But John, thank you so much for accepting to, be our guinea pig. I hope it was as enjoyable for you as it was for us. I leave on, the last word, and thank you so much for me.
Yep, thanks, Laurent, and thanks, John, again for giving up your time while you're on clinic, especially, and to relay this information to everyone watching. Great study, and speaks a lot for the obviously homeostatic mechanisms going on in the brain, and really has now paved the way for a lot of clinical research to take place as to exactly what we should, when we should be treating these cases. So fantastic, really. Again, thanks very much. Thanks to you, your team, and take care.
All right. Thank you very much, Laurent, Simon. It's been a pleasure. And thanks to all of you for joining us. And again, send me any questions, okay? Appreciate it.
Thank you.
All right.
Bye-bye.